Hello, and welcome to the CAP Today webinar for Wednesday, February 28th. I'm Bob McGonigal, the publisher of CAP Today, and I'll be your host and moderate a question and answer session after our single formal presentation. Today's webinar is entitled Combining Clinical Signs and Symptoms with Histopathology for Definitive Diagnosis of Idiopathic Multicentric Castleman Disease, or iMCD. This very important program is made possible today by a special educational grant from Ricordati Rare Diseases. We want to acknowledge Ricordati for this grant, and we want to thank them for their support for this important program. Our single presenter today, and I'll say more about her in due course, is Dr. Jade Neff, Assistant Professor of Pathology at the Duke University Medical Center in North Carolina, and we'll get underway shortly. But of course, before anything else, I have some housekeeping hints for you. I recommend that you may wish to refresh your browser. I want you to know that you've got live help available to you at all times. We've got real people who can help you. You can call them at 858-345-5916, and they'll help you with any technical question that you may have. Also, you'll see a Q&A box. That's right below the pictures of Dr. Neff and myself on the right-hand corner, on the right-hand edge of your screen. At any time, you can feel free to also let us know if you have any technical problems or issues, and you'll get immediate attention. But of course, the Q&A box is largely for the purpose of your comments and your questions that you'll direct to Dr. Neff. We'll hold those, and we'll do them all after she finishes her presentation. I do want you to know that we aim to be able to post all the slides and audio in about a week at captodayonline.com, so you can review and refresh. It is the case that you are very, very likely to get some email both from us and perhaps from Ricordati after this, so I want to alert you to that. Finally, it's important that you know that CAP Today does not endorse any product or service that may be mentioned today in the course of this webinar. Also, any remarks of mine are purely personal. They're not to be taken as official policy of the CAP Today or, of course, the College of American Pathologists. So once again, our webinar is entitled Combining Clinical Signs and Symptoms with Histopathology for Definitive Diagnosis of Idiopathic Multicentric Castleman Disease. And our faculty, as I mentioned, is Dr. Jade Neff, MD and PhD at the Duke University Medical Center. She is, you should know, acting on behalf of and is a paid consultant to Ricordati Rare Diseases, Inc. The information in this program is fully consistent with FDA guidelines and FDA-approved prescribing information. As such, the program is not CME accredited. Dr. Neff, you should know, trained at the Mayo Clinic in Rochester, and she is boarded in both hematopathology and molecular pathology. So it's a particular pleasure for me and a thrill to work with Dr. Neff, and I'm going to introduce her now, and she can begin her program. Dr. Neff.
Thank you for that introduction, Bob. It's a pleasure for me to be here, an honor to be able to speak to you all today. This afternoon, I'd like to tell you a little bit about Castleman disease, and in particular, Idiopathic Multicentric Castleman Disease, or iMCD. If you're like me, maybe you've learned about this in training. Several years ago, I remember learning about Castleman disease, but it was sort of like a cute little pattern that I could recognize and diagnose as a pathologist, but there wasn't really a diagnostic urgency to it. And so today, I hope to impress upon you that iMCD in particular is a serious disease with significant morbidity and mortality, and that it is very important for us as pathologists to diagnose because there is a treatment available for patients, which does improve their quality of life. So in today's talk, I'll start with a little bit of background and pathogenesis, and I'll focus quite a bit on the diagnosis, particularly from a pathologist perspective and how we can help make that diagnosis for patients. And then I'll end with the importance of timely management and the management itself. So Castleman disease is really an umbrella term, and it refers to a heterogeneous set of conditions that really share certain histopathologic features. So the things that you may have learned about already, you know, onion skinning, lollipops, things like that that you might see in a lymph node. But Castleman disease broadly can be divided into two groups. That's unicentric and multicentric. Unicentric refers to diseases that involve just one lymph node site. So you can have a couple of lymph nodes or a couple of areas involved, but it's really one site. Whereas multicentric Castleman disease refers to multiple lymph node areas that are involved at the same time. Now, multicentric Castleman disease can be further divided into different groups based on the etiology. The first being HHV8 related multicentric Castleman disease. And this is, of course, due to infection with the HHV8 virus. And it's often associated with HIV infection in patients, but not always associated. Then there's POEMS-associated multicentric Castleman disease. POEMS is a plasma cell-related condition, and it has to do, or patients present with polyneuropathy, organomegaly, endocrinopathy, a monoclonal gammopathy, and skin changes. So POEMS-associated MCD is a separate category, and then all the rest of the multicentric Castleman disease is lumped into idiopathic, or iMCD. Currently, iMCD accounts for approximately 33 to 58% of all published multicentric Castleman disease cases. This slide is very text heavy, but basically it's there to tell you that the data that you're about to see in the coming slides is based on a retrospective U.S. health claims analysis. So between 2006 and 2020, about 30 million patients were screened for health claims. They looked at ICD-9 and ICD-10 codes and were able to pull out patients who had a diagnosis of Castleman disease during that time frame. And then they looked at those patients and further evaluated whether they had idiopathic Castleman disease based on other laboratory data that were available within this cohort. And they were able to calculate incidence, or the number of patients that are diagnosed each year, and prevalence, or the overall number of patients who are diagnosed with Castleman disease. So iMCD is a relatively low incidence disease based on this retrospective study. There are about 3.1 to 3.4 new cases diagnosed per million in the U.S., and the overall prevalence is 6.9 to 9.7 cases per million. Now, this may seem fairly low, but the one caveat of it being a claims-based study is that the diagnostic criteria for Castleman disease were not as firm as they are now since 2017, and so it's possible that there are cases that were missed in this retrospective study. So there's a possibility that there may be more cases out there. But it's also important to diagnose these cases because these patients do have poor outcomes, and some are even worse than cancers that are more common, such as stage 2 colon cancer, or stage 3 breast cancer, or certain non-Hodgkin lymphomas. One of the problems with diagnosing patients with iMCD is that they're very hard to identify. The disease doesn't affect any particular age group. It can be seen in any age. It doesn't affect any particular race or globally localized population. It can be seen anywhere in any group. And the symptoms themselves are rather nonspecific. They can mimic infections, autoimmune diseases, or malignancies. The patients can present variably. So you can have one patient that presents with fatigue, edema, weight loss, and ascites. And another patient with iMCD can present with organomegaly, so large spleen and liver, and they can have night sweats. Some patients can be just like asymptomatic with a few low-grade symptoms, and some patients can present with multi-organ failure. They'll present to the ICU in multi-organ failure, and they can quickly progress to death. So it's very difficult on the clinical side to recognize these patients. So what causes iMCD? Well, there are three main hypotheses as to the etiology of iMCD. So it's known to be driven by a cytokine storm, but what actually causes the cytokine storm is currently unknown. And there are various studies that are ongoing to try to identify the etiology, but the three main hypotheses include an autoimmune or inflammatory etiology. So something about the patient's immune system makes them hyperreactive or autoreactive, and then they develop this cytokine storm. Another hypothesis is that there is a somatic mutation that occurs. And if this is the case, it's unknown what cell type would harbor the mutation, whether it be macrophages or dendritic cells or plasma cells, but that's another hypothesis, that there's a mutational event that occurs that then leads to this cytokine storm. And the third major hypothesis out there is that there is an, as of yet, unidentified pathogen that's driving this. So it would be similar to the HHV8-related MCD cases, except some unknown pathogen. But regardless of the etiology, iMCD is caused by a cytokine storm, and this is driven by IL-6. So it's characterized by dysregulated IL-6 activity. Now, IL-6 is part of the normal immune system. It's responsible for upregulating the inflammatory response. It helps activate B cells and plasma cells. But when you have unregulated IL-6 activity, that's what leads to the things that we see in patients with iMCD. So increased VEGF production leads to the formation of blood vessels and things, and that's what we see on these lymph nodes. The increased plasma cell and B cell overgrowth leads to the lymphadenopathy that we see in patients and the organomegaly. They can also have increased CRP and SUD rate and present with DIC, other things that are related to unregulated inflammatory responses that are, again, due to this IL-6 activity. So you can see that patients can present then with this cytokine storm, and if it is very severe, that's how it leads to organ failure and death. So how do we diagnose iMCD? Diagnosis is difficult. As I said, on the clinical side, patients can present with a variety of symptoms that overlap with a variety of conditions, such as infectious etiologies, different malignancies, or autoimmune disease like rheumatoid arthritis or lupus or macrophage activation syndrome. So on the clinical side, this is very difficult to diagnose, and patients often will bounce around for months or even years to different specialties based on how they're presenting before they are actually diagnosed. Fortunately, in 2017, David Feigenbaum with the Castleman Disease Collaborative Network published a set of diagnostic criteria that have made the diagnosis of Castleman disease a little bit more straightforward. The diagnostic criteria involve establishing some major criteria and some minor criteria, and then excluding exclusionary criteria. And specifically, to look here, if you focus up at the top, the major criteria, there are two of them and they both must be met. One of them is that the patient must have multiple enlarged lymph node groups. So more than 2 lymph node groups with lymph nodes that are greater than 1 centimeter. The second criterion is that the histopathology must fit with iMCD diagnosis, and that's where pathologists come into play. So we need a pathologic diagnosis in order to make a diagnosis of Castleman disease. There are 11 minor criteria. They're divided into two groups, the clinical symptoms and the laboratory parameters. Two minor criteria must be met in order to make a diagnosis of iMCD, but one of them must be a laboratory criterion. So the patient can present with, for example, elevated CRP and hepatosplenomegaly, and that would satisfy the two minor criteria. And then, of course, before a diagnosis can be made, all of the exclusionary criteria must be met. So basically, the patient can't have a known infection, they can't have a known diagnosis of rheumatoid arthritis or lupus or other autoimmune disease, they can't have a known diagnosis of a malignancy. If they have any of these, then the diagnosis of iMCD cannot be made. Diagnosis of iMCD has become more understood in the community, such that now it is included in its own chapter or section of the 5th edition of the WHO. In the WHO, it states that, similar to what was stated in the paper published by the CDCN, the diagnosis must fulfill major criteria, minor criteria, and then exclude other diseases. And they list here the essential diagnostic criteria, which I've already discussed, the enlarged lymph nodes and the lymph node pathology. And importantly for us pathologists, the WHO goes on to specify a little more clearly that the histopathology must contain at least grade 2 or grade 3 regressed germinal centers or plasmacytosis. And I'll show you in a couple of slides what that looks like. And then, of course, they must have met clinical and laboratory criteria. But the bottom line is pathologists are important. We're essential in making this diagnosis. This is not something that can be just diagnosed on the clinical side. If we don't see the pathology, or if we can't make that call that these are Castleman, that we see features consistent with Castleman disease, then they can't make that diagnosis, and then the patient can't receive the treatment if this is indeed what they have. So one of the problems with Castleman disease, or the tricky sides of it from a pathologist's perspective, is that the pathology itself can be very variable. We have a range of histologies from lymph nodes that are characterized by primarily regressed germinal centers, all the way to pathologies that are characterized by abundance of plasma cells. And so part of the trick in making the diagnosis is to understand the variability of the pathologic presentation and to be able to put it together. And that's where I appreciate the paper, again, that was published by Dr. Feigenbaum, that gives us some scoring criteria. But before I go there, I would like to point out that an excisional biopsy is key to making this diagnosis. Now, I know that there are some groups out there who do needle core biopsies. My understanding is that they do several needle core biopsies, so it's never just one biopsy, but you might have 4 or 5 or 6 biopsies lined up. But in my personal experience, I prefer to see an excisional biopsy, and I really think that's the best way you can really look at the entire histology of the lymph node and really put it together, what you're looking at, and to be sure that you're not just getting a sampling error and just seeing, one regressed lymph node off on the side or something. You really are seeing the whole picture and can be confident in the diagnosis that you're making. So the scoring criteria that were proposed by Feigenbaum et al. in the CDCN paper in blood include assessing 5 histologic features in the lymph node and grading them based on what you see. The first of these is regressed germinal centers, and they recommend grading on a scale of 0 to 3. Now, they don't have any hard cutoffs on what makes a 0 and what makes a 3 versus a 2 versus a 1, but I can tell you in my practice, I tend to use quartiles for this parameter. So, for example, 0 to 25% regressed germinal center. If I look at all the germinal centers, if 25% or less are regressed, then I'll give it a 0. 25 to 50%, I'll give it a 1. 50 to 75%, I'll give it a 2. And 75% or greater, I'll give it a 3. Again, this is just my personal practice, and I've spoken with a few other hematopathologists that I've met with just over, through networking, etc. And other people also have a similar quartile system that they use. The next histologic feature to grade is follicular dendritic cell prominence. Again, it's graded on a scale of 0 to 3. For me personally, I will call something a 3 if the follicular dendritic cells tend to take up the entirety of the germinal center. Another thing I do is if I can see them clearly at a 4x objective, it's very obvious to me and jumping out at me, I'll grade it a 3. If I can't see them at all, if I have to go hunt around for them, of course that would be a 0. And then, a grade 2 might be, I can see them, I might have to look a little closer. They don't necessarily cover the entire germinal center, but they are there and they are pretty prominent. I'll give that a 2. And then a 1 would be less than that, not quite 0, but not quite 2. The next histologic feature to score is vascularity. So again, you're looking at the prominence of the vessels within the lymph node, and you can often see them more easily if they're hyalinized. So a grade 3, this is very easy. You can see these hyalinized vessels often from a lower power, and this is where you'll see the characteristic piercing of the germinal center by the vessels, so that lollipop sign that you learn. If the vessels are grade 2, you might see them. You might have to look a little bit harder, go a little bit higher magnification to see them, but they definitely are more prominent than, say, a grade 1, where maybe you only see 1 or 2 vessels, or a grade 0, where you really don't see the vessels very, very overtly. Hyperplastic follicles is another histologic feature to grade. I think of hyperplastic follicles as being opposite to regressed germinal centers. So these are the follicles that look like your prototypical reactive germinal centers. But again, for this particular feature, I like to use quartiles. So if more than 75% of my follicles are hyperplastic, I'll give it a 3. 50 to 75, I'll give it a 2. 25 to 50, I'll give it a 1. And less than 25%, I'll give it a 0. And the last histologic feature to score is plasmacytosis. This can be the most tricky one if you're not used to seeing a lot of lymph nodes and you're not used to seeing how many plasma cells are present in a normal lymph node. So I kind of use the first thing I do is break it up into grade 3 or grade 0. Grade 0, you don't really see any plasma cells or just rare plasma cells. Grade 3 is where you see sheets of plasma cells in the interfollicular areas. So in between follicles, if you're seeing, the interfollicular area is just packed with plasma cells, I would give that a grade 3. For me, a grade 2 would be something where I might see focal, aggregates of plasma cells. So maybe it's not sheet-like, but, I see aggregates here and there, or plasma cells are fairly easy to see in between the follicles. A grade 1 would be where I'd have to hunt around to see them, but they are there, definitely more than grade 0. So putting it all together, iMCD lymph node pathology tends to be one of 2 types, either hypervascular, which tends to show more the regressed germinal centers with the hypervascularity and FUZ prominence. Those tend to go together, and that would be a hypervascular subtype of iMCD. On the other end of the spectrum, you have the plasmacytic type pathology. So these tend to be characterized by the plasma cells and the hyperplastic germinal centers. But if you have mixed features, so you may have some plasma cells and some regressed germinal centers, this would be called mixed pathology. So again, making the diagnostics on the pathological level can be challenging. First of all, the pathology isn't specific. So you can see something that looks perfectly like Castleman, and yet if the patient has a diagnosis of rheumatoid arthritis or lupus, you can't make the diagnosis of Castleman disease because lupus and rheumatoid arthritis could have lymph nodes that look very similar. But one of the things we can do, at least as pathologists, is to rule out some of the known mimics that we have control over. So we can rule out lymphoma. If you get your lymph node, you can do your flow cytometry, or if you see plasma cells, you can get your kappa and lambda stain and rule out monotypic plasma cells. Anytime I get a lymph node that looks like it could be Castleman disease, I always get HHV8 stain to make sure it's not HHV8 related. I will get Ebers often. If I see the plasma cell type with a lot of plasmacytosis, I also order an IgG4 to make sure that it's not IgG4 related disease. But on the histologic level, if you can rule out all those other entities, then you can move forward with your annotation of it being Castleman disease-like or Castleman disease. If you're suspicious, and maybe you have a small biopsy or you have only a needle core biopsy, it's okay to tell the ordering clinician that you need another biopsy, or that you maybe need an entire lymph node excision. But it's okay to say that, and it's important to say that to be able to make the diagnosis. There are sort of two levels of certainty that are accepted in diagnosing iMCD, and this really applies to the clinicians and pathologists, so the person who's putting it all together. But if you can call a definitive diagnosis of iMCD, you can be definitive about it if you meet all the major criteria and the minor criteria, and you've excluded the exclusionary criteria. If you have met the major criteria and the exclusionary criteria, but you have not met the minor criteria, then a diagnosis of probable iMCD can be made. I just want to end, or not end, but mention TAFRO. So TAFRO is a subtype of iMCD, which has a very severe or aggressive presentation. So it's like on the far end of the spectrum. TAFRO patients present with thrombocytopenia, anasarca, or ascites. They have reticulin fibrosis in the bone marrow. They have renal dysfunction, and they have organomegaly. Patients with TAFRO have very severe disease and actually have a higher likelihood of death than patients presenting without TAFRO. Next, I'll show you a case study. So this is a case that I ran across in my practice, and I like to present it because it illustrates how as a pathologist we can help make the diagnosis of iMCD. So this was a 19-year-old woman who was found at home unresponsive following a seizure. She was hypotensive and febrile at the time. She was admitted to the ICU at our hospital. She was intubated. She was started on pressors and antibiotics. And we really had very minimal medical history on her, except we did have a recent diagnosis of lupus from an outside hospital. We knew that she had a healthy childhood, but 6 months prior to this presentation, we noted that she was 36 weeks pregnant and admitted to the outside hospital with weight loss, joint pain, and a rash. At the time, she had elevated bile acids. They gave her betamethasone. She got a C-section. Her symptoms resolved, and she was discharged. Then 2 months prior to this admission, the current admission, she was again admitted to an outside hospital for altered mental status and abdominal pain. At the time, she was found to have hemolytic anemia and proteinuria. She did have a renal biopsy which showed podocyte effacement, and at that time they did give her prednisone and her symptoms improved and she left. She checked herself out. So this is where the working diagnosis of systemic lupus or lupus was made at the time, was based on these presentations at the outside hospital. So here at our hospital, in the ICU, she had an initial workup, and we see laboratory values that are very abnormal, including pancytopenia. She has elevated creatinine and sed-rate, and her ferritin is very high. Her triglycerides are high. LDH is high. She also has low complement and haptoglobin. Her blood cultures are negative, and her CSF is normal. She did get a CT scan of her head, which was read as consistent with PRES. And she did get a CT of her abdomen and pelvis, which showed widespread bulky lymphadenopathy. So given this finding, the differential diagnosis at the time was that this was lupus with macrophage activation syndrome versus lymphoma. And so because of the suspicion for lymphoma, she did get an excisional lymph node biopsy. This is what it looked like. The flow cytometry was negative for any monocytic B cells or any abnormal T cells. And you can see that overall histology is, the overall architecture is preserved. There we have patent sinuses. We have some follicles. Well, they're a little bit difficult to see, but you can see some here and there. And no sheets of abnormal cells or anything like that. A CD21 stain highlights some germinal or some follicles that aren't readily apparent on H&E. So you can see these here on H&E, which correspond to these here. But then there are some others that aren't super easy to see on H&E. And sometimes I find that when I do a CD21 stain and find sort of surprise follicles, sometimes that's a clue that there may be some regressed germinal centers in there. Looking a little closer, we do see sort of this characteristic onion skinning of a regressed germinal center. We see here a little bit of follicular dendritic cell hyperplasia, and this right here, I think, is a little bit of a lollipop sign, so a vessel that's piercing the germinal center. In another area, we see a lot of vessels that are fairly prominent, fairly easy to identify. And then here, in the interfollicular areas, there were areas where I saw a lot of plasma cells. Not quite sheets, but definitely increased plasma cells. I did some additional immunostains. The kappa and lambda IHCs were polytypic. IgG4 was not increased. HHV8 and Eber stains were negative. So at this time, I have essentially a benign lymph node. Like I didn't see any obvious lymphoma, but I did see some regressed germinal centers, and I saw some plasmacytosis. And anytime I see regressed germinal centers or plasmacytosis in a lymph node that doesn't have an obvious other pathology, I do consider Castleman disease. And of course, in the context of the patient having diffuse lymphadenopathy, this would be idiopathic multicentric Castleman disease, or iMCD. Now, as I mentioned, iMCD is a diagnosis of exclusion. I was able to exclude various malignancies and a few infectious etiologies with my pathology workup, and the clinical team was able to exclude other infectious etiologies and other malignancies with their workup, with the exception, of course, of lupus or HLH/MAS. So because these exclusionary criteria were not met, therefore I could not make a diagnosis of Castleman disease. This is sort of my practice on how I report Castleman disease or Castleman disease-like findings with various degrees of certainty. So if If the clinical team is suspicious of Castleman disease, they know that the exclusionary criteria have been met and the minor criteria are met, and they're only waiting on my diagnosis, and I see Castleman enough features to qualify, I will call it Castleman disease on my top line. If, however, the clinical team is less certain, maybe it's not on their radar, or maybe not all the minor criteria have been investigated, but I see pathology that really is a slam dunk case for a Castleman-like picture, I will say something that's a little bit less definitive, but still up in my top line. I might say something like benign lymph node with Castleman-like features. And then in my comment, I would include a reference to the paper so that they could go in and look up the rest of the minor and exclusionary criteria to see if they could make the diagnosis on the clinical side. On the other hand, if I know that the exclusionary criteria were not met, or the minor criteria are definitely not met, or if the histology is more borderline, that's when I'll fall into more of the descriptive type of language. I might say follicular hyperplasia with polytypic plasmacytosis, or something like that that's more descriptive. And then in my comment, I might have a list, a little bit longer list of potential etiologies, and Castleman could be one of them. But I wouldn't come out and just name it Castleman if I wasn't, absolutely sure. So for this particular case, the histology was fairly supportive, but at least according to what we knew at the time, the patient had a pretty secure diagnosis of lupus. And so this is how I signed it out. I was kind of descriptive at the top, dermatopathic changes, regressed follicles. And then in my comment, I said, these findings are compatible with lupus, and although, there are some features that are Castleman-like, the fact that she has lupus trumps the diagnosis. And I left it at that, and I signed it out. Then the next morning, I got a phone call. It was a conference call. We had the rheumatology team on the line, the hemonc service on the line, and they called me, the pathologist. And basically they said, we don't think this is lupus. Like, we know that she came in with an outside diagnosis, but we're not thinking that anymore. Part of it is because she's not responding to the traditional treatments for lupus and macrophage activation syndrome, which is what we thought she had. Can you please reevaluate for iMCD? So I said, of course. I pulled back the cases, and this is just showing you how I scored it. I don't think scoring is absolutely required, but I did in this case. But for this particular case, I thought that she had grade 3 germinal centers. I thought that her follicular dendritic cell prominence was about grade 2. It was moderately prominent. I did see very prominent vascularity. I did not see any hyperplastic germinal centers, and I thought that the plasmacytosis was mild to moderately increased. I didn't see sheets, but I definitely saw more than normal background. And so because I saw some plasmacytosis and some regressed germinal centers, I said that this was mixed pathology, and then I revised my diagnosis. I amended my report to say that, well, in this particular case, I didn't come out and call it Castleman again. I think because I think the clinical team was still deciding how much of the minor criteria were met, but I did write a new comment that just said, these morphologic features would be compatible with a diagnosis of Castleman disease, and I gave them the reference so that they could go and make sure that they met all the other criteria. They did do additional workup, and as a matter of fact, so the patient met both of the major criteria. She ended up meeting several of the minor criteria, and all of the exclusionary criteria were excluded. So her final diagnosis, ultimately combining pathological and clinical workup, was iMCD, or Multicentric Castleman Disease. They halted the anakinra. They started zoltuximab, which is an anti-IL-6 therapy. It's sold under the brand name Sylvant. her pancytopenia and inflammatory markers improved, her symptoms improved, and she was able to be discharged home. You know, she went from the she went from the ICU to the floor, and then was discharged home within a week or so, and with plans for a continued cetuximab therapy every 3 weeks. So, why is it important to diagnose iMCD properly? These patients, if they're not treated appropriately, they have a 35% mortality rate within 5 years. You know, this mortality rate is worse than several cancer types. The disease is progressive. It's characterized by flares, and each time they come back, they'll be a little bit worse. This is a similar slide to what we saw in the beginning, just to let you know that these next few slides are based on a retrospective claims-based analysis, so similar analysis to what I described before, only instead of looking at incidence and prevalence, here they're looking at additional hospitalizations, additional symptoms, and things that these patients presented with after diagnosis. So again, in this retrospective study, they screened 30 million patients. They found almost 500 that were diagnosed with Castleman disease, and of those, just under 300 were diagnosed with iMCD. In this graph here, you can see that so the blue bars are the year prior to diagnosis, and the orange bars are the year during diagnosis. So the patients would have been diagnosed here, in between the blue and yellow bar, and then here in between the blue and orange bar. So inpatient hospitalizations that lasted longer than 5 days, about 35% of patients had inpatient hospitalizations in the year before, whereas only 15% had hospitalizations in the year following, and then only 5% had hospitalizations in the year after that. There were more patients who presented to the emergency room. Almost half of patients had presented to the emergency room for disease flares in the year prior to diagnosis. In the year after diagnosis, that dropped a little to 40%, but by 2 years out, that was down to about 13%. So this data shows that once patients are properly diagnosed and they can begin proper treatment, their representation to hospitals and to emergency rooms goes down. This graph shows other serious comorbidities that can be seen in patients with iMCD. So patients can develop renal dysfunction, liver dysfunction, diabetes, heart failure. Again, just showing that patients who are not properly treated can develop some serious comorbidities. These graphs here show the incidence of malignancies, other malignancies that are diagnosed after Castleman disease. So the Castleman disease diagnosis is made, and then within a few years, they are then diagnosed with either myeloid malignancies or solid tumor malignancies. So again, iMCD is a chronic disease. It can have very different presentations, but it is progressive. Patients tend to present with a flare, and then maybe they'll be a little, treated a little, and then they'll come back with another flare, and it's progressive until eventually they have multi-organ dysfunction and death. Fortunately, there is a treatment. The treatment guidelines are published both in the Castleman Disease Collaborative Network, the CDCN, and in the NCCN. The treatment guidelines are published, and currently, yes, this is the CDCN website. Both the CDCN and the NCCN recommend anti-IL-6 therapy, or cetuximab, as the recommended first-line treatment for iMCD. There are other treatments. Currently, siltuximab is sold under the brand name of Sylvant, but there are data that show that patients who are treated appropriately with this therapy have very good outcome, and the comorbidities and the risk of death and other things that we see in patients that are untreated are vastly improved. So in summary, Castleman disease itself refers to a heterogeneous group of disorders. iMCD is the subtype of multicentric Castleman disease that has no known etiology, so it's not related to HHV8 and it's not related to Poem syndrome. It is rare, but it is potentially life-threatening and has high morbidity and mortality. We know that it's driven by an IL-6 mediated cytokine storm. We know that diagnosis is difficult, but it's critical so that these patients can be recognized and can receive the treatment that they need. The pathologist's role is key in making this diagnosis because that is one of the major criteria that we fit these histopathologic features. And for a pathologist to make the diagnosis, there are 5 different histologic features that we can examine and grade according to a scale in order to help us make our determination of whether or not the pathology fits with iMCD or not. It's important to recognize these patients, so if we see it on the pathology side, even if the clinician isn't thinking of it, it's important that we at least mention it in their comments, maybe provide a reference for them, just to get it on their radar, that they can work the patient up, and if the diagnosis is made, then they can receive the appropriate treatment. And of course, there are therapies that are available out there. Again, the NCCN and the CDCN both recommend siltuximab or Sylvant as the first-line treatment for iMCD. And I would like to thank you for your attention. And at this time, I will take any questions.
Dr. Neff, I want to thank you on behalf of all of our audience. What a marvelous presentation. I have to tell you, if Dr. Castleman were around, he'd be very, very proud to know that he had a fellow pathologist with such great grasp of a difficult condition. So I thank you.